first instance, I can see that there is a lytic lesion in the left iliac wing, which has got sclerotic borders, and it is also surrounded by wide area of lucency. I cannot see any soft tissue component. It has got internal some calcification specks. Bilateral hips show degenerative changes, but no other obvious pathology within the hip joints is seen. Bilateral sacroiliac joint shows some sclerosis on the sacral side, but there is no widening or erosion of the sacroiliac joint, and the sacrum appears unremarkable. Pubic symphysis, both ischial tuberosities are within normal limits. So I would like to further investigate this pathology in the left iliac wing on CT. So can I proceed to
So,
CT?
what do you think? What is your differential on this X-ray?
The differential in this X-ray can be a chondrosarcoma, as the patient is old age, and I presume that there are some rings of calcification in this lesion. The other thing can be a metastatic deposit, a myeloma. These are my top differentials in this case.
You want to see a CT scan?
Yes, sir, I asked for a CT. Or MRI would also be fine, but firstly I want to see CT.
I've given you a CT. Can you see it?
No, sir. No, sir. I can just see you. I can see the
Okay.
CT.
Just 1 second. Can you see the CT?
Yes, sir. I asked for controls. Sir, should I
Okay.
scroll?
Yeah.
Yeah. So as I am scrolling down, sir.
Just 1 second. Is it working for you? I don't think so. It's working for you.
No, sir. Yes.
Okay, let me scroll for you.
Okay. So there is a large lytic lesion in left iliac wing, which has got sclerotic borders, some internal specks of calcification. However, I do not see a gross bony destruction. There is bony expansion, actually, and some internal ground glasses. I would like to see the bone, the soft tissue window. So there is bony expansion, however, no destruction. So this can be a lytic metastasis, or this can be plasmacytoma, or else it can be some benign pathology like a simple bone cyst in this location. Given the age of the patient, um, aneurysmal bone cyst is less likely. GCT is a possibility. But however, it is more in the towards the sacroiliac joint and the posterior elements. However, I would still like to see MRI of this patient for further characterization of the abnormality. Okay, I'm provided with MR axial fat T2 fat sat, in which this is hyperintense, well-defined bony pathology. It has got hyperintense signals on T2, no cortical breach. Sir, can I see corresponding T1? No extension into the muscles. It is hypointense on T1 and no hyperintense component seen within it. So no hemorrhagic component, no fluid levels. So I can, so can I see the contrast?
I don't have contrast and you don't need it.
So given
Why do you want to see contrast? Okay, so given all this, please conclude it. Candidate one, can you hear me?
hello, sir, you have unmuted. You had unmuted me. Can you listen to me now?
Yeah, I can listen to you.
Yeah.
Please.
So
So
this is
conclude the case.
so this is a simple bone cyst, benign pathology of the left isling wing, and with no pathological fracture, no soft tissue extensions, and no cortical breach. I would inform my finding to the referring clinician and refer this patient to ortho MDT. The management would be conservative, most likely, in this case. However, I would like to see the previous records and also to see any multifocality if this is associated with other bones lesion. If there is any previous record, I would like to see that one.
Okay, thank you. Some or the other, it is not moving to the next case automatically. Let me, I'm going to give you 3 cases and then I'll give you a feedback. That's
Okay,
going
sir.
to be the format today, but yes, can you hear me?
Yes, sir.
1 month old baby.
Okay. I'm present. Sir, you would scroll for me, sir. I am presented with the MRI axial T2 weighted images of 1 month old baby, in which I can see T2 axial images, in which I can see that there are hyper intense signals within the basal ganglia, in the medial temporal lobes bilaterally, in the internal posterior limb of the internal capsules, which are nodular rounded uh, lesions, and the ventricular system is not dilated. There is no midline shift. Uh, so these rounded lesions in medial temporal lobes uh, and in bilateral basal ganglia, thalami, in 1 month old baby, I would like to ask if there is any history of mm, um, developmental delay or anything like this. The brainstem, midbrain also shows hyperintense signals. Can I see the corresponding T1? T1 imaging. These abnormalities are slightly hypo intense to the brain parenchyma. Sir, can I see DWI and flare and just in flare also I can see hyperintense intense abnormality within the medial temporal lobe, basal ganglia, and internal capsules. So in a 1 month old baby, these abnormalities can be due to some congenital torch infection, uh, and they can be some mitochondrial problem involving the deep gray nuclei, um, as it can be. So can I see DWI?
No restriction.
Okay. So these abnormalities are not restricting, so hypoxic injury is less likely. Uh, Sir, is there any relevant history, the baby?
Nothing relevant.
Mm. It can be some also some leukodystrophy involving the deep gray nuclei. So mitochondrial disorders and torch infection are my top differentials in this case.
Okay. Anything else?
Any encephalitis can also be a possibility involving medial temporal lobes, and the deep gray nuclei, viral encephalitis.
So anything else you want to see?
Mm. Sir, contrast imaging is there?
This is contrast. No enhancement, basically.
No enhancement, yes.
Yeah.
There is no enhancement. There is no significant enhancement. So,
So in
just
conclusion,
yes, sir. Sorry.
so give me your conclusion.
So in summary, this is a non-enhancing, non-diffusion, no diffusion restriction abnormality centered on the basal ganglia, internal capsule, and medial temporal lobes bilaterally symmetrically. So bilateral symmetrical involvement is likely some congenital process ongoing. It can be some mitochondrial disorder or some congenital infection, torch infection. I went to inform my finding to the referring clinician and advise for the workup regarding torch infections and any mitochondrial metabolic disorder in this baby.
Okay, thank you. Right. So this patient is a 74-year-old female. They were worried about weight loss, etc. A CT cap was done. The chest part is normal. I'm showing you the abdominal part. So you want me to keep scrolling for you?
Yes, sir. Yes, sir.
Okay, I'll go to the top and coming back now.
So this is axial CT with contrast, in which I can see liver is grossly unremarkable, stomach is normal, gallbladder is normal, and the tail of the pancreas is bulky with internal cystic areas and some patchy enhancement. And there is no surrounding fatty stranding, no peripancreatic collection. Pancreatic duct is not significantly dilated. Can you show me the sir pancreas body again? I do not see any vascular thrombosis. Vessels are patent. Head, neck is unremarkable. The distal body and tail are expanded with heterogeneous enhancement and multiple small like cystic foci. So this is an elderly female. In this age group, serous cyst adenoma of the pancreas is a possibility. Another was I cannot though see any calcification. Maybe there was a tiny speck of calcification up. Uh, Yeah, here there is a tiny speck of calcification which further supports my diagnosis. Other possibility can be intraductal pupillary mucinous neoplasm. However, I do not see any ductal dilatation of the pancreatic duct. And the third possibility can be cystic pancreatic neuroendocrine tumor. However, it is not enhancing to the degree neuroendocrine tumors enhance. No surrounding fatty stranding do not suggest any infective or etiology post pancreatitis, and there is no relevant history of pancreatitis. So I would like to see any lymph nodes. Mm, I do not see any abnormal lymph nodes. So can you show me the adrenal, left adrenal? Uh, Here's normal. And there are no metastatic deposits in the liver. Sir, can you scroll down?
Okay,
Screen is
so
not enhanced.
this is my area of interest, so we'll keep it
Okay,
here. So
okay.
what is your then conclusion?
So my conclusion is a pancreatic cystic tumor involving the tail and distal body of the pancreas. And sir, can you again go to the main? I do not see any vascular thrombosis. I see some specks of calcification in tiny cystic areas within this lesion. So, in summary, this is a cystic pancreatic neoplastic lesion, likely serous cyst adenoma of the pancreas, and it is closely abutting the anteriorly placed bowel. It is in close approximation to the bowel. However, I do not see any fistulation. The fat planes with the bowel anteriorly are blurred. However, no vascular thrombosis. My top three differential are serous cystic adenoma of the pancreas, serous cystic tumor of the pancreas, intraductal pupillary mucinous neoplasm, or cystic neuroendocrine tumor of the pancreas. I will inform my finding to the reference clinician. I would like to review in my routine practice. I would review the bone windows in the chest to see any metastatic lesions, because the possibility of malignancy cannot be ruled out on imaging alone. And I would refer this patient to hepatobiliary MDT for further management and biopsy correlation.
So you're going to advise the
Stay.
biopsy for this.
So firstly, I think the MR characteristics should be established and MRCP should be done to see its relationship with the pancreatic duct.
Mm-hmm.
And pancreatic protocol should be done to rule out any vascular component in this case. Okay. So, two-weighted imaging. This lesion is showing multiple cysts, variable signal intensity. It has a thin capsule and internal hypointense septa and some internal hypointensities which are likely due to calcifications. So can I see contrast imaging? Sir, is there any arterial phase? So
This is the arterial phase.
on arterial phase, there is a focus of intense enhancement within
That
this
is not
lesion.
in the, don't worry about that enhancement. That is a
Okay.
vessel. So
So there is peripheral enhancement with internal septal enhancement and a solid component here, which is also showing enhancement here, this one. Uh, so again, this is a multicystic, microcystic appearance of the lesion with peripheral enhancement and septal enhancement and central non-enhancing component.
what is your conclusion?
Sir, my conclusion is serous cystic tumor of the pancreas would be my top differential in this case. Serous cystic.
So are they malignant or they are benign?
Mostly, so they are benign. They are benign.
What do you mean mostly? Is there a malignant potential in them?
Sir, in they occur in elderly female And there is
So
very
what's the age
little
group?
malignant potential. Older age group, in older age group.
What do you
This is
mean
a
older? What is the average age of
uh,
presentation?
sir, in 70s, 60s to 70s, this is a grandmother lesion called mostly serous adenoma.
So you were saying that there is some possibility of malignant transformation.
So this is rare. Mostly these are benign.
Okay, we stop here. So let me go through the feedback. But before we go through the feedback, it is very frustrating for me because usually I go from one case to other on my series of Cyrex cases. Today it is not allowing me in a slightly different thing. So we will come back to your cases. Now, can you see my slides?
Yes, sir.
Okay, so this is for everybody. Let's quickly go through. Uh, I think we have done a session on this a few weeks ago, but I just want to quickly go through with you regarding the changes in the marking as far as oral exam is concerned, as far as Viva exam is concerned. Uh, to keep it simple, what I am going to tell you, you won't even, grasp everything. But to keep it simple, just remember it like this, that from your perspective, the candidate's perspective, nothing has changed. But from the examiner perspective, many things have changed. And the examination has now become even more objective and, should I say, fair. So a lot of thought process has gone into it. But you don't have to worry because from your perspective, it remains the same. Having said that, it is a very good idea to, to know what you are going to be judged on. The scoring system has changed, and that is also a very good idea to know that. You remember previously there were marks from 4 to 8. You could not get less than 4 marks, and 6 was a pass marks. And we used to talk in the terms of, if you get 6, let's say 5.5 in other and 6.5 in another one, you can compensate it. So that system has completely gone now. So let's revise it from June 2025, what has happened. The last exam, June 2025, was, I think, only for UK candidates, including IMGs or NHS workers who were working in, but I think nobody from overseas participated. So your exam, it will be a good revision for you, what will happen. Now, what is going to happen is that each day, all the cohort, whoever is having the oral exam on that particular day, will get the same cases. So this will make it very fair. From the perspective of the examiner, there are two examinations, should I say two stations. In one station, there is a 30-minute Viva. Each Viva is divided into 15-minute and 15-minute, one examiner one and examiner two. But what has changed is timing has not changed. What has changed is that during this period, examiner number one will show you three cases. Examiner one number two will show you three cases. So overall, this will be 6 cases in one station. Now, when I use the word cases, means patient to keep it simple. And some of these will have only one modality, some will have two modalities, and even three modalities can be shown, just like previous times. But the examiners are going to push you because they want all of you to go through these 6 cases. Having said that, it's not hard and fast. if a candidate is not moving on, might not see all six cases. But generally speaking, they have got prepared Viva questions. They will ask all of the candidates the same questions, 100% same questions. Having said that, if a candidate does not reach that point, how can they ask those questions? And in the feedback to the candidate one today, I'll refer back to that. Uh, Now, each case is marked by both examiners, and they have got four domains to mark on: radiology knowledge, observation, clinical reasoning, clinical safety and management. I think we should do a separate talk on what does it mean, but I'll just briefly touch it. But you have to understand, I am again saying that don't overload yourself. Basically, you know what you have to do and don't try to be artificial. But uh, the um examiners convert whatever you are saying into four headings and mark you accordingly. Now, Uh, then comes communication. Now, communication is extremely important in the exam. I'll show you a slide to tell you that what it is. And you are given, the communication is whatever happens in a station, the examiner will mark it and then multiply it by six. That number is multiplied by six, and the communication is marked in the same domains as the other bit. So uh, if you see here, these are the four domains: radiological knowledge, observation, clinical reasoning, clinical safety, and management. The marks they give, actually, they will use this code. They will write E for excellent, perfect, clear pass CP, just passed JP, borderline fail BF, fail F. If you go to the website, whatever I'm showing you here is available on RCR website. And all of these things are given, and they have given a breakup of what exactly excellent means and what exactly clear pass means, and it's a good idea to go through it. In real terms, excellent gives you 4 marks. So you can get 4 is the maximum. In radiology knowledge, you can get 4. Observation, you can go 4. Clinical reasoning, you can get 4. Clinical safety and management, in one case, you can get 4. But uh, if you are getting less, then this is going to be the mark sheet. And total marks are 480. uh, each examiner actually gives you 120 marks. We are now calculating 4 examiners here. And this 480, the pass percentage calculated is 58.5, but the pass marks, etc., are determined on each attempt by some statistics according to some models. You don't have to worry, simple as that, because this is what they have to do, not you. Uh, so, for example, uh, this is a mark sheet, a hypothetical mark sheet by examiner, in which these are the cases 1, 2, 3, 4, 5, 6. And, for example, this candidate got E, CP here, JP here. So they will create a whole chart. And then in communication, for example, 3 are given, they will multiply by 6. Overall, each examiner will give you 96 plus 24, 120 marks. Uh, Total comes out to be 480. Now, communication is extremely important, and as I have just elaborated, that you are going to be marked on that. So basically, what does the word communication mean? You know how the system judges you. For example, you are working in UK, and there is a clinician uh, who came over to the department and you are going through a scan with him or her. So that should be your mindset with the examiners. So basically, communication means that you have to speak very clearly. Your expression should be, very clear, and you, whatever you are saying should be understood by the examiners, and vice versa. Whatever they ask you, uh, for example, they ask you a question, your answer should be very precise and to the point. For example, if you want to ask, can I zoom it? Can I go to this window or that window? This is part of the communication. This is you speaking with them. And on the other hand, when the examiner asks you, and you have you understood that, and your answer is concise and to the point. One of the key techniques for communication is talking through the case. Talking through the case, just think like this, that you are in the department and the surgeon comes and says that I'm very worried about this. Can you tell me what is happening? And you are talking through the case with the surgeon, that this is the colon and you can see there is a thickening. I can see a perforation here. I can see that. And of course, it's an exam, then, keep talking, keep talking. So this is the method to sort of communicate with the examiner and show them good communication skills. So there are many hypothetical examples, but I don't want to go into details of the terms radiology knowledge and the other four terms. But just to give you an idea, that radiology knowledge means uh, understanding radiological principle, imaging modalities, disease processes. So, for example, if examiner asks you, how does a renal cell carcinoma look? And you say that it is typically solid enhancing mass on CT. It can have necrosis and hemorrhage. It can go into renal vein, IVC, etc. So this is where your radiology knowledge is checked. Of course, if I start asking you, DNM classification, everything else, everything is radiology knowledge. So radiology knowledge. Then it's observation. Observation is what we do as a radiologist, describing the finding accurately and interpreting it. So, for example, there is a opacity in right lung on a chest X-ray. If you describe it that there is a soft opacity in right lung, uh, with which is obliterating the right heart border, and air bronchogram sign is positive. This is in keeping with consolidation. So this is, you have described the finding and you have interpreted the finding. So this is observation. Then the third domain is clinical reasoning. Now, in clinical reasoning, key point is the history which has been provided to you. The history which has been provided, you have to. So this is one of the key take-home points, is that when the examiners tell you something in the beginning, may it be age of the patient or the clinical history, you have to be very, very attentive, and your thought process will completely change according to the clinical history provided. And so the word clinical reasoning means you integrate imaging findings with clinical information to formulate a differential diagnosis or a management plan. And finally is the term clinical safety and management. So clinical safety, of course, there are too many examples which can happen. So this is and a few questions about managements, etc. What is done? So these are the four domains which are checked. Now, where relevant, I will today point out when I am giving feedback to the candidates, might point out few of these. So let's go to the cases. Now, this case, uh, candidate one, are you with us?
Yes, sir. I was
Okay,
muted.
this was your first case. Now, key thing, 53-year-old male, and you picked up osteoarthritis. By the way, there is a cam type of deformity here. I don't want to go into details. You can see a bump here at the neck, and 50 for a 53-year-old, the OA is quite advanced, and this is because of cam type. Having said that, my main emphasis was here. This is a 53-year-old. 53-year-old who has got a lytic type of lesion with marginal sclerosis. Now, this is thick marginal sclerosis. You ask for a CT, actually, the role as far as characterization of bone tumors are concerned in your FRCR exam is MR. And CT, of course, in osteoid osteoma, you can ask for a CT for nidus, etc. So the key thing in fibrous dysplasia is fibrous dysplasia can be, uh, you know, basically it is replacement of the marrow by cystic spaces, and then they ossify up to a degree. They can be ground glass, and they can become more sclerotic than that. And of course, they can be lytic also. So it's not a must that it will be only ground glass. Key finding is the marginal sclerosis. Now, if you see, look at how thick is the margin. It is very, very thick. And this is known as rind of orange appearance, quite pathognomic for fibrous dysplasia and nothing else. Another thing is that in your differential diagnosis, so one thing, candidate one, which I have seen is that you go into rounds. So you have to what we call finish the case. You have to go in a very, very succinct and method. Your method. There should be a method. You are describing the finding, then you are reaching a differential and then giving a principal diagnosis. At that point, you should not start describing it again and then describing it again. And this is a pattern which I saw in you, even in your pancreatic case and even in the brain case also. So this is the key take-home point from my side for you. You
Thank
have
you,
to,
sir.
yeah, you have to just learn to go very systematically in your brain. There should be headings. I am describing the case, number one. Then the describing means you are interpreting the case, right? And as your mind is working according to your radiological knowledge and the clinical history provided, you are making a diagnosis. Now, and that diagnosis you might reach going through a differential diagnosis. So, okay, you start talking, this is either this, either this, either this. And then the examiner might ask you, or you should, if you have got a principal diagnosis, then say that this is a principal diagnosis. And then comes management. What will you do? And things like that. You cannot go back to start describing it or start asking for something else at a later stage in the way you tackle a case. So this is the key thing which I wanted to highlight for you. Now, as far as this is the MR. So on MR, uh, there is, please remember that bone tumors, for characterization, still most of them are characterized on plain film. Most of them are on plain film. Of course, MR has got a role, but here you can see a cystic lesion if your baseline knowledge is that fibrous dysplasia can also be cystic. Here, if you see carefully, look at on a T1 weighted sequence, look at the signal of the margin, and the margin is sort of more more intense. So it is a benign lesion, very well defined. And in the end, you did ask for a CT, so I showed you a CT. Actually, there was no need of a CT, but CT shows the same thing. And the point is that in your exam, key point from my side is that for bone tumors, never ask for an CT unless it's an osteoid osteoma, nothing else. In the real world, of course, we use CT, particularly for planning, etc. But use MR, plain film and MR. So in the end, your final conclusion once again was simple bone cyst. Simple bone cyst. This a age group for simple bone cyst? And the answer is
Sir.
no. So here comes your clinical reasoning. You remember those headings?
Yes, sir.
So this is how you are going to be marked.
Sir,
So
but fibrous dysplasia also I dismissed on the basis of age in the beginning.
say again.
So fibrous dysplasia also occurs in younger age group. That is why I dismissed. Although I was thinking, but I
If
dismissed
there
on the
is a
basis of age.
patient with fibrous dysplasia, when there is fibrous dysplasia, it will stay as fibrous dysplasia for the rest of their life.
All right. So we can include it in our differential in the elder population also.
So the point is that this was a slam dunk fibrous dysplasia. I was not, this was the type of case where there was an emphatic diagnosis. In these kinds of cases, the examiner will push you what is your differential. So the examiner is pushing you. And to tackle it, it is slightly different way you have to tackle it. You have to tackle it uh, diplomatically. Say, once again, stay firm. So here, when there is an emphatic type of diagnosis, stay firm. So I could have asked you a leading question. Can it be malignant? This will be my question. And you have to stay firm. So say that the lesion is very well defined. It has got thick marginal sclerosis, and these are features of a benign lesion. There is expansion of bone. There is no destruction of bone. This is in keeping with the benign lesion. I'm not worried about malignancy. So stay firm. And this is another technique of the examiners, which they do. They do check your confidence. Okay, your next case this is a case of, now my system is working good. I was able to go to the next one, so it will be less frustrating. So this is the case where the you can see all of this bilateral symmetrical high signal. In the chat, has anybody got the diagnosis? Have you got the diagnosis in the chat? NF1, good, well done. So if you see here, these were high signal intensity foci, but here, I'll come back to this, but if you see here, the key finding is this thing is the midbrain. Anterior to the midbrain is the suprasellar cistern. In the suprasellar cistern is optic chiasma. There is a mass sitting there. This is the optic chiasma which is thickened. If you trace it further, even on this sequence, you can see the optic nerves. The optic nerves are thick and they are tortuous. Of course, then we had the luxury to see other sequences. Now, what is happening? So I did intentionally show you till actually orbits, but basically there is bilateral optic nerve gliomas. It is thick optic nerves which are going all the way. This is the optic chiasma. The optic chiasma is the thing which is projected anterior to the midbrain on the axial slice, which I was pointing out. Then it goes all the way through the optic tracts into the lateral geniculate bodies. And actually, as I proceed posteriorly, it is going all the way into the optic radiations. But in this particular case, it is more than that, because it is going from there into the midbrain down, and also going right and left, and ultimately also projecting into the basal ganglia. It is if a lesion is there which is not explainable on which is not in continuity with the parent tumor, then it might be, for example, this one can be a focal area of signal intensity, which we can see in NF1 cases. Now, I showed you other than that contrast. Please remember that optic nerve glioma are low grade, grade 1 tumors, so they might or might not enhance. Enhancement will not change the diagnosis. So this was a case of NF1 because you could not reach the diagnosis. I had selected some questions for you, and in the exam also, they will select one or two odd questions for you. But if you don't reach that point, they cannot ask that question and they might go to the next case. And you are going to lose marks in some of the domains which I have told you. So this was NF1. And then Uh, so here again, my same feedback which I told you in case number one, you go into rounds. You have to learn to close the case and just give a diagnosis, because here also, even going through all of this, then you ask for an MR much later. So let me tell you the theory behind serous cyst adenomas. Serous cyst adenoma is a benign tumor. The Please remember that cystic lesions of the pancreas, serous cyst adenoma, mucinous cyst, we use the word serous cyst neoplasm, and previously we used to say tumor, now we say neoplasm, SCN, or MCN, mucinous cyst, or IPMN, intraductal papillary mucinous tumor. So the point is that in all of the other tumors, there is potential malignant transformation potential, uh, but in serous cyst, there is none. So this is an emphatic thing. Now, in this particular case, the classical signs of a serous cyst adenoma, eh, nodular edge. Uh, there are small cysts, and because of which it is a nodular edge. Marginal calcification. You could have asked for an MR, which I had kept for you. On MR, it becomes clear. Enhancement will not change anything, by the way. It will not change anything because the septa and etc. can enhance. So this is a serous cyst adenoma. In the end, once again, you kept in your differential diagnosis intraductal papillary. Actually, you had ruled it out, and you had ruled it out that I can consider this, but there is no duct dilatation. Then in the end, you again kept it back. So please remember that in cystic lesions of the pancreas, what we do is that we can do aspiration. In the aspiration, for example, in UK, we use mostly EUS guided aspirations, go through the stomach and pancreas sitting there. In these aspirations, because a differential, not in this particular case, but I am giving you some theoretical knowledge which is asked in the exam. In mucinous lesions are taken, there is a malignant transformation risk. So you don't sit on mucinous, and at times you offer surgeries, but at times you do follow-ups according to the location of the lesion, or if the patient is not compliant, etc. Mucinous cyst neoplasm are what we call mother tumors. So the average age of presentation is about 47. In serous cyst, it is 62. This is the average age. Mucinous can become malignant, serous cannot become malignant. So what we do is that other than the radiological features, we do cyst aspiration because in another context, at times a mucinous cannot be differentiated from a pseudocyst. So we do a aspiration, we do amylase level, we do CEA, we do CA 1919 and we 199, and we do mucin levels. And of course, cytology can also be done on the aspirate. So with, in real world, many of these are at times pseudocyst where the history of pancreatitis is not known. And if you pick up mucin, then whole of your mindset goes, you have to offer the patient that, this is a potential in future, it can become malignant. Let's get rid of it. However, having said that, there are many patients who will not go down that route. Okay, thank you very much.
Thank you,
Candidate
sir.
2, are you with us? Let me check if she needs unmuting. Let me check. Candidate 2, yes. You are
Hello, sir.
candidate.
Good evening. I'm available, sir. Candidate 2.
Okay, good evening. So this is a 71-year-old uh, headache. Okay, the patient had lot of upper respiratory tract infection and has also got headache. They say that rule out any intracranial, 71-year-old intracranial hemorrhage. This was
Sir,
the
can I
question.
try requesting the remote control and try to
You
scroll?
can ask, you can ask.
Thank you.
So I've given you the control.
So I've been provided with CT head plane of a 70-year-old male patient who had prior history of respiratory tract infection is now presenting with headache. I'll take a moment to scroll through the given images and then start presenting my findings. In my initial scroll, I cannot appreciate any gross intra or extraaxial bleed. The ventricular size is normal. Bilateral sylvian fissures are unremarkable. The scrolling is stuck. I'm trying to scroll, so scrolling is lagging a bit. I'm still trying to scroll it to the bottom so that I can have a look at all the sequences. The brainstem in my initial scroll also appeared unremarkable. Dental artifacts are appreciated, which is degrading the image quality at the base of the brain, but I could not appreciate any crowding at foramen magnum, ruling out the possibility of tonsillar herniation. I'm going back again. The vertebral and basilar arteries are of normal density and not hyperdense. In my actual practice, I would also look at bone windows to look for any sign. Thank you so much. So I'm looking at the I cannot appreciate any major signs of sinusitis. The frontal sinus, ethmoid sinus, and maxillary appear unremarkable. I'm going to the area of middle ear cavity and mastoidal cells. Some air foci are appreciated within the soft tissues of bilateral temporal lobes and within the left optic canal area.
Sorry, I lost you there. Where you said left what?
Left I'll scroll through that point. Sir, I could appreciate few air density areas within the left optic canal over here.
Optic?
And sir, few soft air foci are also appreciated in the bilateral soft tissues of the temporal lobe, temporal soft tissues,
Okay, so
within the
yeah. So what's happening? I'll
yeah
take
over here.
just 1 second. So I think you have pointed out this air. So where is this air anatomically?
Yes, sir, over here.
So what do you mean? I am asking you anatomically, where is this air?
Sir, this is in the within the cavernous sinus, and it is also seen to track along the left optic nerve in the region of the left cavernous sinus and tracking along the left optic nerve.
Right. So how can you explain that?
So keeping in view the history. The patient had history of upper respiratory tract infection, and now he is having severe headache. So with these air foci, so the cavernous sinus had got fishless communication with some paranasal sinus, posteriorly sphenoid sinus.
Do you see it on this? Anything?
No, I'm trying to yes, with
I'm
the
scrolling.
left.
Hmm.
Thank you. So I can appreciate some more air lucencies within the some linear air lucencies are also tracking along the left petrous part of the temporal bone. So they're all patchy, they're scattered bilaterally. So yes, over along the petrous segment of the left ICA, there are also some air lucencies and along the left temporal lobe.
So why do you think there is air?
So there must be some. I'm trying to look for any bony erosion of the sinuses or mastoid air cells to establish this air leak into the.
So there is no leak. Sorry, what I meant was that there is no bony erosion or anything. So
Yes, I could not appreciate any
hmm.
bony erosion. I could not appreciate any definitive abscess formation in the soft tissues to justify these air loculi.
How will you manage this case? What will you tell the
I would,
clinician?
I would discuss the case with the referring physician, and I would ask them to go ahead with the MRI brain and neck to establish the cause of this and to rule out the possibility of any intracranial air lucencies as well. However, in CT head, I could not appreciate any pneumocephalus.
On MR, there was no change in the findings. On the contrary, actually, the findings
Can
are.
sir, can I please have a look at the coronal reformats of these of this CT brain?
Which window do you want? You want bone window?
Sir, the same
Yeah, here you
bone
are.
window and then the soft tissue window. So I can still see multiple air lucencies in the soft tissues of bilateral skull base area in the temporal lobes along the pterygoid plates.
So just conclude. And what you want to advise?
So considering this, I can. This does not look to be infective or inflammatory. I would rule out the possibility of any trauma in this patient. I could not appreciate any bony destructive pathology or any fracture. I would compare these findings with any prior images to look if these are the acute changes. I could not appreciate also any pneumocephalus or midline shift. So sir, I would discuss the findings with the physician and look for any other presenting symptom of the patient besides headache related to any upper respiratory tract infection. Any?
No other symptom, nothing else. Okay.
I'm sorry. Yes, sir.
Okay. This is a 68-year-old male with pain epigastrium. Over to you.
Yes, sir, I am able to scroll. So, a 68-year-old male patient with abdominal pain. I've been provided with post-contrast CT abdomen, including lung basis. In my initial scroll, I can appreciate few fluid density, simple thin-walled hepatic cysts. Atherosclerotic changes are appreciated within the abdominal aorta. The portal vein appears patent without any thrombus formations. Visualized part of the spleen appears normal. The images are skipping, so kidneys also appear normal for the age. So the infrarenal part of the aorta, I can appreciate the abdominal aorta is grossly distended with peripherally displaced atherosclerotic calcifications and curvilinear hypodense area along the
I'm not interested in the aorta. The patient has got epigastric pain. Please concentrate on the upper abdomen.
Sir, I'm scrolling and it's going a bit slowly. I'm going upwards again,
Let me scroll
cranially
for you.
again.
Let me scroll for you.
Sir, I've left it. Sir, can I please have a look at the area of the lesser sac? There I could appreciate any behind the... Yes, I can appreciate a well-defined heterogeneously enhancing centrally hypodense area in the lesser sac close to the abutting the gastric wall. However, it has a clear fat planes with the stomach as well as with the pancreatic parenchyma. I would like to establish its relationship with the surrounding vessels. It is seen clearly separate from the splenic vein as well as the celiac axis. In my actual practice, I would use the coronal sagittal reformats to look if it's exophytically placed within the pancreatic body. Though in axial images, it does not appear to arise from the pancreatic parenchyma. So the same lesion, well defined, is demonstrated, is renoted. It is seen clearly of the pancreas with clear fat planes with the stomach as well. It does not appear to have a vascular origin. The vessels, though the images are jumping, but the vessels appear closely lined vessels appear to pass by the lesion discretely without any connection, without any having clear connection with any vessels. There's I would look at other organs to look for any pathology elsewhere as well. In this, I could not appreciate any perilesional fast running around this lesion. Spleen and kidneys appeared unremarkable. There were few hepatic cysts. Gallbladder also does not show any
What is this?
signs of
Give me the
So,
your final.
considering if it's an isolated finding without any other organ abnormality, this can be neuroendocrine. It can be a neuroendocrine tumor, solitary lesion. But I would like to, in my actual practice, I would be looking at all of the scans, including all of the organs, chest and the bones, to look for any other pathology. It can also be less likely. It can be a nodal met if there is any known primary. It has a very indistinct borders with the stomach. So my third differential would be a less likely possibility of GIST, but it is solid and enhancing significantly as well. However, GIST and for since it's not clearly arising from the adrenals or pancreatic parenchyma, so pancreatic tumor would be, I would exclude the possibility of a pancreatic tumor. To further confirm the neuroendocrine tumor, I would look at the other images, and also I would suggest further imaging for this, like the nuclear medicine imaging, to evaluate for its to further characterize this, like the octreotide scan. And I'll review the previous images as well to look if it's a new pathology. I'll discuss my findings with the referring physician, and this case needs discussion in MDT as well for further management. And
Classify for me pancreatic neuroendocrine tumors.
so it can be insulinoma, gastrinoma, VIPnoma. So if the patient is having depending upon the symptoms, gastrinoma would of course give multiple
I asked you to classify. I am just interested in you naming names.
So insulinoma, gastrinoma, and
So what do you think this is?
sir, the enhancement pattern is for is significant. It is giving significant enhancement.
Okay.
I could not appreciate any gastric ulcer, no associated gastric volume. So
that's it. Your next case. This is a male 36-year-old came with headache.
sir, the scrolling is with you, or I'm unable to scroll. Yes. 36-year-old male patient with headache. I've been presented with CT head, non-contrast, demonstrating few hypertense areas in the left cerebral hemispheres with central hypodensities. The left-sided sulci and garai are effaced, raising concerns for left-sided edema. There's subtle mass effect with pressure effects on the midline falx. These are multiple in number. I could appreciate another hypertensity in extra location, bilateral frontal regions. In dural location. Another area of hypertensity is also noted in right parietal lobe. The ventricles, I could not appreciate any intraventricular.
One second. Just 1 second. Where is this, anatomically speaking, where is this?
Sir, what
This
the
high
lesions
density rounded focus.
in high
I was asking you, where is it location wise?
sir, in bilateral in left high frontal regions.
Uh, I don't think so. You understood my question. Can you see my mouse? I'm using the mouse.
No, sir, I'm sorry, I cannot appreciate your mouse. The screen is scrolling.
I've got a extra laptop with me just to see what is happening, and I can see my mouse very well.
The sir, uh, this is my mouse.
Don't use, okay, you are not scrolling now. You're
Yeah,
not.
I'm not scrolling, sir.
Now, do you see my mouse?
I'm so sorry, sir. I cannot. Are
Don't
you
worry.
scrolling it because my screen isn't being scrolled at the moment?
Okay,
Yes, now I can see. Now I can see.
so now I have given you a T2 weighted MR for
MR,
this.
sir.
Yeah. So I'm just scrolling it for you.
Sir, I can appreciate the surrounding CSF cleft around the larger ones on the left side. So these infratentorial lean is noted. There is one on the left right occipital horn of the lateral ventricle. So these appear to be extra axial because of the CSF cleft that is seen around the right larger altered signal intensity lesion. And I could also appreciate a lesion in CP angle areas probably. No, sorry. So these are multifocal, intraventricular as well as extraaxial, predominantly left frontoparietal region altered signal intensity areas appearing to be iso to hyperintense on T2 with surrounding CSF cleft around the larger ones, causing mass effect on the surrounding structures, but I could not appreciate any hydrocephalus. Can I see, sir, can I see sagittal images as well or coronal to look for any, if there are any other lesions as well? So these are the major ones. I would like to have a look at the post-contrast imaging if available to look for their enhancement pattern. So these are homogeneously significantly enhancing with the larger one demonstrating central necrotic component. Dural tail is appreciated. Dural meningeal enhancement is also noted, giving the sign of dural tail. In my real practice, I would look at all the sequences, including the sagittals, to look for any spinal lesions as well. Considering the multiplicity and the given radiological findings, my top differential in a young male patient would be NF2 with multiple meningiomas. Um, um, I would like to I would convey my findings to the referring physician and request them to get a whole neural axis imaging to look for multiplicity of the lesions, including the spinal tumors as well. The patient needs genetic screening, and the further management depends upon the symptoms, because there are multiple, and if the patient is developing any symptom relevant to these larger ones, neurosurgical consult is suggested for that. I could not appreciate any obstruction, no transtentorial herniation, or any signs of acute hydrocephalus.
So if you are worried about NF2, what is the criteria for NF2?
So
To
these
reach
are in NF2 there would be multiple either meningiomas, ependymoma, or schwannomas. I could appreciate all of them to be characteristics of meningiomas. That I would like to look at the rest of the neural axis to rule out any schwannoma or ependymomas as well, because there was one intraventricular tumor growth as well on the occipital horns of the left side in subependymal location. And I could
which
not
is the
appreciate
most important tumor regarding the definition of NF2?
schwannomas
Of what?
uh,
Which
of
nerve?
IS. Sir, internal auditory canals.
Do you see anything there?
Mm, no, sir, no significant enhancement.
Okay, thank you. So, my feedback to you is that you have to learn how to close the case quickly. You are taking too much time and you are again going, I have seen this pattern with you quite a few times in these three cases where you pick up a finding, you do not concentrate on finding, and you twice I think you said that in my usual practice I will also see this, I will also see this. Now you have picked up the principal finding, finish that. And if there is something needed, then at a particular point, even if you take the examiner wants to show you something, you can reach that point. So the point is that time is critical, and I'll give you the feedback on other cases. This one was different. You did it beautifully well initially because I was happy with your what we call description, and you were talking, so that was brilliantly done. Communication 4 out of 4. Uh, and when you asked for a bone window, you actually picked up the finding. Now, in this particular case, uh, I don't think so you were at fault in this particular case. The only thing was radiology knowledge. You remember that heading, radiology knowledge, and then the clinical context of things. Please remember that the same case with intraparenchymal venous gas has come in the exam. Same case which I am showing you. So what happens is that this is an incidental finding. If you Google it, you can read a few studies. In my experience, I've picked up quite a few, one of them with incidental venous gas in the and this particularly in the cavernous sinus. So the mechanism is very interesting. Usually, these patients, this venous gas can be uh, uh, because of iatrogenic, which is uh, if if gas was there in an auto injector and things like that. There have even been recorded deaths because of that, if you pump in too much of air. Please remember the venous gas will go into the heart and then go into the lung and then go up. Interestingly, many a times there is a patent foramen ovale, which is there is a percentage of human beings, I think quite a significant 3% or 5% is the percentage in which foramen ovale remains patent and gas can go up. That's a different mechanism. That's a different mechanism, iatrogenic. Other mechanisms are very interesting. This is other mechanism is retrograde uh, gas into the head and neck. So what happens is that, for example, if there is a brachiocephalic vein stenosis, sometimes what happens is that there is cuffing by the patient, and this was the relevant history in this particular case. So the thoracic pressure is increased, and the concept is that there can be retrograde extension of that gas, which into the vein, which has gone into the brain and even in head and neck. So the idea was, if you don't know this, you will never reach the diagnosis. Your thought process was very good, and the way you tackled the case was very good. But because your basic knowledge was not there, you could not reach the diagnosis. These cases are usually of, no issue. You will just sit on them, and nothing needs to be done, and that is it. To ask for an MR, etc., that was, I think, not needed. So otherwise, you did describe it, your thought process was good. You were also looking for if there is any bony abnormality to explain that. So this was an incidental, and I warn you, this case has come in the exam, in the past, I mean to say. Now, this is your second case, which is an neuroendocrine tumor, extrapancreatic neuroendocrine tumor of the pancreas. Now, this is the pancreas. Now, around the pancreas, if you see something, uh, this is a neuroendocrine tumor. Please remember that they can be extrapancreatic, they can be multiple, they can be multiple. There is a concept of gastrinoma triangle, which is in this region where I am pointing out. This region is where you will see in your exam. You did well where you ruled out any rugal thickening, etc. But again, this I have seen a pattern in you. You again just lingered on and on and on. Management wise, the thought process which you gave me was again lacking. For example, you asked for a nuclear scan. Why a nuclear scan? Very rarely you will do a nuclear scan in a special scenario. I asked for a classification, and you started going into the details of this, and this comes under the definition of communication. When you speak, it should be understood to the examiner, vice versa. When the examiner speak, you should answer that question. So I did not ask you to start describing that what will happen in it was a sort of a last question from my side. Give me a classification. So if you see neuroendocrine tumors of the pancreas, open a textbook and it will tell you functioning and non-functioning, and then there will be names: insulinoma, gastrinoma, VIPoma, somatostatinoma, and carcinoid, etc., etc. Now, all of them can have. I could have asked you more questions. How do you manage these cases? So management, of course, depends on the scenario. Is it functioning or not? This will be one question. It will be always a MDT approach, but you should have those concepts. Please remember, all of them have got a potential malignant, percentage-wise, potential for malignant degeneration. Insulinoma is the minimum. It is about 10%. Gastrinoma is about 60%. So you cannot just sit on it. And some of these are close to 100% as far as malignancy is concerned. So they are always tackled, hyper enhancing lesion around the pancreas. And again, in your description, what you did was that you described it and you started describing it once again and once again. Fat planes, stomach, even in your conclusion, I was, you should have been emphatic. It is a neuroendocrine tumor, extrapancreatic neuroendocrine tumor, and my differential is this, this, this. And in the real world, what we do is that if they are functioning, actually some of the surgeons, they just want to get rid of it. They tell the patient, and if the patient is willing, they just remove it. And of course, you can do a EUS guided, FNA and things like that. Of course, the advanced imaging like nuclear scanning, venous sampling, etc., in most of the cases, they are not needed. Key point is look for arterial phase enhancement. And if it is around in this region, even in the small bowel, arterial phase enhancement is the key. This is a neuroendocrine tumor. So I was not interrupting you because just to see how do you close the case, and you took too much time. Now this is uh, I think part of the problem in this case was that when I was asking you questions, maybe it was not projecting, on your screen. Having said that, here you picked up the meningiomas, which were fine. You could have asked for a bone window because is there some hyperostosis here? And there was a bit of hyperostosis in this region. Now, uh, this this is in the ventricle. Actually, you did mention it in the end because I was asking a leading question, but at that time it was not projecting for you. Now you uh, you know eh, quickly ask for the next. This is a feedback from my side. Quickly ask for the next. For example, in this case, you went on this T2 weighted sequence. You did well. I'm not saying that you said anything. This one was in the ventricle. This was a question. And by the way, this is not the occipital horn. Occipital horn is down here, and you cannot see it. This is the trigone atrium of the ventricle. So this is not the occipital horn. Now, what do you do in your clinical practice? Go for contrast. And so to ask here for a T2 coronal was not needed. And because you asked for it, I just gave it to you, but you wasted your time. Another point is that when I was asking you about NF1, and the key definition of NF1, I was asking you definition, but you were not very elaborative. What is NF1? Look at the definition of NF1. If a patient has got bilateral acoustic schwannomas, it is an correction. I'm using apologies. I meant NF2 actually. So what is the definition of NF2? If a patient has got bilateral acoustic schwannoma, NF2. So the definition is done if you've got bilateral tumors. Number two, you are in that number two category. Multiple meningioma, this was only 36-year-old. Multiple meningiomas with ependymoma. Actually, that was an ependymoma in the ventricle and acoustic schwannoma. I gave you a hint. Look for that. And you did not. And the point is that I would have, then it would have been a good practice to ask for, I want to magnify it. That was the key in this case. Actually, the patient has got bilateral acoustic schwannomas. And here you are. You see, this is enhancing here, and another one is enhancing here, bilateral. But you did not ask for that. So conclusion, I could have shown you this, but the way the Viva went, I did not show you. And here the key thing was that if you see here, there was a ependymoma in the cord also. So you went into the neural access bit. The way you tackled it, you took too much time. So once again, my feedback to you is try to close the case. Try to close the case, and the time is yours. Okay, thank you very much. Candidate 3.
Hello, good evening. Yes, I'm here.
Okay, candidate 3, this patient uh, is a 32-year-old male, correction, female, with bilateral hydronephrosis on ultrasound. So CT was done. Over to you.
Yeah, okay. Shall I request control?
Yes, please.
Okay. I requested.
Yeah.
It's not, no. Yeah, it's scrolling now. I think, yeah.
I want you to concentrate on the kidneys.
Yeah, okay, sure. So I'm presented with a plain axial cuts of CT images of the abdomen for the female patient complaining of hydronephrosis. I'm examining both kidneys. Both kidneys show dilated pelvic calyceal system, or however, the pelvic calyceal system, the contents appears to be more like isodense to me, more than of a fluid nature. She's a 32 years female. And the upper third ureter is of normal caliber. So this can be either bilaterally dilated pelvic calyceal system with intracalyceal component that results in this iodensity, not the hypodensity, or it can be bilateral intrapelvic calyceal lesions, which is not. I don't think so. I'd like to know if there is like post-contrast images to examine to see if these are enhancing lesions. Or also in the left kidney, I noticed that, yeah. Yeah, thank you. So now I'm examining the delayed phase of the post-contrast multiphasic kidney scan. Both kidneys, actually, these proved to be not intra. I don't know why it is going up. It proved to be not intra calyceal. Okay, because the pelvic calyceal system, the contrast is going through the pelvic calyceal system, and these are like parapelvic lesions that are not enhancing. In my practice, I would, to be more sure, I'd measure the HU density pre and post contrast to ensure that it is really not enhancing. However, subjectively, it doesn't appear to be enhancing. So these are likely bilateral parapelvic cysts that can have like a slightly proteinaceous component owing to this in slightly more than hypodense content, and these are not hydronephrosis, and there is minimal pelvic ectasia, maybe due to the compression of the system. However, this may not need any, if the patient is not really complaining, I would refer this to the referring physician, and they are most of the time incidental findings that are not enhancing. And I refer this to the referring physician. If it is bothering the patient, the urologist may proceed. And
Proceed with what?
I don't know if there are. I don't think there is a surgery for this. I think it is. I believe it is. There is no further management for the parapelvic cysts, as far as I know. If they are really parapelvic cysts.
Okay, so what technique has been used for this phase of, CT which you are looking at?
This is the delayed phase of I think multiphasic kidney, where I can see the contrast going through the pelvic calyceal system, so I can see both ureters and the pelvic calyceal system.
So why is there contrast in the portal veins then?
Yeah. So maybe, yeah, it's a late venous phase, but why if both kidneys are I mean, seeing the bowel and the solid organs is like, yeah, a venous phase. The portal vein and the IVC are seen. However, there is contrast seen in the pelvic caduceus system. Down the ureters till the bladder. So, and I just have seen the previous plane. I think the delayed phase, the contrast should have been washed out of the kidney and into the pelvic caduceus system. I have just seen the plain CT, and there was no contrast within the pelvic caduceus system to assume that she has taken contrast before or something. So I don't know.
Okay, thank you.
Maybe. Okay.
This is a 64-year-old female, chest pain, weight loss.
60-year-old female, chest pain,
Or
weight,
64, yeah.
chest pain and weight loss. Yeah. Okay, so I am presented with an AP chest X-ray of a 60 years old female patient that's complaining of chest pain and weight loss. I'm examining the most striking abnormality for me, a thickening of the right paratracheal stripe, I think. Thickening of the right paratracheal stripe. There is
Can I
no.
stop you there? The right paratracheal stripe is thickened because of a bit of rotation, so don't worry about that.
Oh, okay. Okay, so there is no striking abnormality for me, so I'll go through the system. The heart cardiac shadow appears normal. The mediastinum is slightly shifted to the right, and there is a loss of the there is slight loss of the right hemithorax volume compared to the left. So I'm
Don't
checking.
worry about that. That is also projectional. Please continue.
Okay, so the mediastinum appears normal, and you said that this is normal. So the hilar, both hilar regions appear normal. So I'm checking the lung parenchyma itself. I cannot catch any striking findings. The both diaphragms are normal. The costophrenic angles are clear. The diaphragmatic areas appear clear. The retrocardiac area appear clear. The breast, I mean the shadow, is there missing right breast shadow?
No, that's also projectional. Don't
Yeah,
worry.
okay. Okay, so it appears normal too. I'm examining the bones, the clavicles. I mean, it is seen on the left, not on the right. The distal end, it appear, I think, normal, and the shoulder joint appear normal. The ribs appear also normal. I cannot see any fracture or any lesions. So she's complaining of cough, right?
Yes. And weight loss.
And weight loss, cough and weight loss. So I'm re-examining the lung parenchyma. It's maybe there is like bilateral reticulonodular pattern or
Look at
not
the
there.
ribs once again. Look at the
The
ribs.
ribs.
Yeah.
Okay. The ribs. Okay. These are the posterior aspects.
Do you want to change the window?
Yeah, maybe. Yeah, a little bit darker. Yeah, and yeah. I mean, okay. I'm sorry. I'm just taking my time to examine the ribs because I cannot like see any sclerotic lesions. However, I think this rib here, I mean, sorry, the left eighth rib is slightly expanded here. However, I cannot really appreciate.
Expansion is not an issue.
Yeah. Okay. There are maybe there is like slightly sclerotic lesions here at the right at the posterior aspect of the right
Right.
seven.
Yeah. Do you think if you don't move your mouse. So
Yeah.
now I
Yeah.
am
Okay.
moving. Do you think that this here there is anything abnormal?
I'm sorry because I cannot see your mouse.
Right, you cannot see my mouse. Okay, left suprahilar region. Anything abnormal?
Left suprahilar region. Yes. Okay. So, so next to the aortic knuckle, there is like an ill-defined consolidation with speculated margins,
Can I stop you? Can I
ill-defined
stop you
opacity.
there? Can I stop you there? Now you are moving your mouse, so that should not be done.
Yeah, I'm
Mark
sorry.
can point out, but as you are talking, you should not do that. Okay, please
Yeah,
continue.
okay. So, next to the aortic knuckle, I can appreciate an opacity with speculated margins. This opacity can be uh, uh, either a mediastinal or chest wall in origin, all parenchymal. However, given on the X-ray, it has obtuse margin, so it can still be mediastinal or chest wall. However, I'd like to proceed to CT chest to identify the lesion and localize it. Yeah, thank you. I'll scroll. So I'm provided with long window of a post-contrast CT chest. I'm taking my axial cuts. I'm taking my time to examine the long window of the chest. I'm specifically trying to examine the region of concern. I saw, yeah, here it is. I saw on the PA chest X-ray, it appears to be at the consolidation at the anterior segment of the left upper lung lobe that shows a cavitation. With speculated margin. Thank you for giving me the. I would have asked for the mediastinal window. So this is basically a it is abutting the mediastinal pleura, showing extra mediastinal invasion abutting the arch of the aorta. So this is likely a tumor that shows a cavitation, bronchogenic carcinoma. That is the next step. I assess for the invasion to stage the tumor. So I can see that it's breaching the mediastinal pleura, abutting the aorta. I'm examining for the pulmonary artery for the remaining of the vessel. There is some soft tissue here at the aortopulmonary window too. Okay, I'm scrolling down to see its extensions. I want also to examine the bronchi. Here it is. The bronchi would be appreciated more. I mean, the main bronchus and the upper branch is apparent on the mediastinal window. However, it will be.
Anything else? Any other window you want to see?
1 second, I just finished examining this window till the end. There is bilateral relaxation atelectasis. I'm concerned here, other than the lesion with this opacity here. I want to see the coronal to see if it is coronal mediastinal window to see if it is continuous with the lesion or if this is just an enlarged lymph node, a mediastinal lymph node. Can I see the coronal post-contrast before examining the bone window and returning to the parenchymal window?
Why do you want to see the coronal? I don't have a coronal.
Because I'm concerned with this soft tissue. I don't want to the soft tissue that is in the
Okay,
mediastinum.
you just give me your conclusion now.
Can I see the parenchymal window and the bone window again, or?
We are running out of time, so
Okay.
give me your conclusion.
Okay, so so this is likely a bronchogenic carcinoma, cavitating bronchogenic carcinoma invading the mediastinum with enlarged aorta. Because it is really ill-defined, but there is some soft tissue in the mediastinum. I would have liked to have extra look to the parenchyma to exclude any other nodules, contralateral nodules to finish the staging, and the bone window to check the bone metastasis. However, on this mediastinal window, I have just noticed now that there is, for example, an osteotic lesion epicentered on this right rib. I would have counted it, but for the time. So this is likely metastatic bronchogenic carcinoma, and I will describe metastatic bronchogenic carcinoma, and I will describe this to the referring team, and this case will be discussed at the MDT, and the next step will be bronchoscopy to confirm to have the histopathological confirmation, and then the staging, okay, to be treated.
Okay, thank you. Okay, this case is a 20-year-old patient has been at home with severe backache, confused for the last 6 days or so. Now the patient has got delirium, so they brought to the A&E and
Yeah, 20 years old.
20, yeah.
Yeah. So I'm given 1 second, please. Yeah. So I am given T. Sorry, this is flare. Yeah. So I am presented with a flare sequence of a 20 axial MRI of a 20 years old male. The striking abnormality for me actually is that the TSF spaces are relatively dilated given the age. I mean, it's like he has brain atrophy. Disproportionate to his age with periventricular hyperintensity. This is a striking abnormality. I am examining the white matter. There are some white matter hyperintense foci. They are not like at the deep white matter of both frontal horns, notably on the right. In addition to the periventricular slight hyperintensity, the posterior fossa appears normal. However, still the striking abnormality is the, can I examine more sequence like T2, T1? Yeah, so this is a T2. Yeah. I'm scrolling through. 1 second. There is still the striking abnormality is the dilated ventricles and the CSF spaces disproportionate to the patient's age with apparently diffuse supratentorial atrophy given the age. Is there any history like clinical history that may be useful?
So what else do you want to see on this MR?
There is like some in the CPA there is like I don't know if it is projection or there is like some iso intensity seen at the right CPA near to the internal auditory canal. So if there is yeah SWI or yeah, 1 second. So this is a SWI sequence of the same patient with, oh my God, diffuse foci of blooming all through the brain parenchyma. All through the brain parenchyma. So putting this together with the brain premature brain atrophy and the diffuse blooming, I mean, this pattern can be seen with amyloid angiopathy. However, it is a disease of older age. Diffuse blooming, differential diagnosis is amyloid and hypertensive. Hypertensive is central, not in this age. Amyloid can give this pattern, but it is of older age. A lot of other can give like septic emboli and so, but this will not result in the diffuse brain atrophy. This is intraparenchymal. It's not in the subarachnoid space like superficial siderosis due to intracranial hypotension can also give this if he has like CSF leak or anything, it can, but it will not explain the brain atrophy. So my prime concern is actually amyloidosis. Maybe amyloidosis. Maybe if he has like primary amyloidosis, it can result in this, or if he has really a leak and prolonged leak and resulting in siderosis. However, it is, I can see it can be intraparenchymal. And maybe the next step will be lumbar puncture to exclude any
Okay, thank you. Thank you.
Thank you.
So this case was simple. You did well, except for one point about management. These are peripelvic cysts. If you Google it, because this is a radiographics article, which is free. So two terms should be in your vocabulary: peripelvic and parapelvic
Yeah.
cyst. And these are peripelvic cysts, which can be sort of confused with hydronephrosis. You did very well because your thought process was absolutely fine. The key point is that where I asked you what will you you said surgeon. Not at all. It's going to be vice versa. You have to tell the surgeons that do nothing. There is absolutely nothing you do with peripelvic cyst.
Yeah.
So management is critical, and this is, the marks for management is what we are talking about here. And it should be actually in UK, we tell the clinicians what to do. So this is our role. Don't worry, just don't do it. There, somebody will even ask you, should we do a follow-up? And the answer is no. Now, another thing which I asked you was technique. This is a split bolus technique CT urogram.
Yeah.
And in split bolus technique, what we do is we save one phase of radiation. Simple as that. So what we do is we do a non-enhanced, then we give contrast. Now, this contrast, we don't scan the patient. At about 7 minutes, we give another bolus, and after 70 seconds of that, we do the scan. So the second bolus of contrast in a way has become the venous phase, and the one which was injected initially becomes the excretory phase. This is known as split bolus technique, and the key role here is to reduce radiation. And split bolus techniques are also used in trauma cases. In this particular case, first of all, there was something wrong here, but if you see here, particularly when I had told you to look at the ribs, so one feedback will be always ask to, change densities. You can even ask for magnified view and things like that. If you see here, this is gone. You can actually see it. You could see it even on the other window. You can
Yeah.
see that this rib is coming, this rib is going like this. Here, the rib is destroyed. So this was visible on the CT. Now, key thing in this particular case is again time. And one thing which I have again seen in you a pattern. In this particular case and in the next case, the examiner gave you a hint and you still persisted. So that is absolutely a no-go area. I
Okay.
told you, forget about this. I told you, do you want to see another window? Now, examiners are never ever going to what we call confuse you or misguide you. So you should have asked there and then. You said, no, I want to first of all see everything and then I will ask for a window. And to look for the coronal, I was not at all interested in the coronal. I'm just looking at your knowledge about your thought process was absolutely fine. The point was taken. The
Yeah.
main thing was something else, which was even here you can see it. Actually, you never went for the bone window because I just had to, you took too much time there.
Yeah.
And if you see the bone window, the main findings are on the bone window. And one of the key findings in is that spine is involved.
Mm.
And here, and this was edge of the film. You see, I am going up, and this is the type of case in which the clinically most significant finding might be at the last last cut. So at that cut, actually, if you see there is metastasis sitting here, and I wanted you to pick that up. Why? Because even if this patient is metastatic disease, this requires an urgent MR for the simple reason that cord compression, even in a palliative case, you have to treat it and things like that. There were other bony mets, for example, here, and quite a few mets. There was one lesion in the rib on this side also. But that one, the one which I showed you on also. So again, the point is that you have to, again, the same feedback as the first two candidates, try to close the case, try to close it and go next. So if you start going into too much of detail, and then you don't have the luxury to do that and
Yeah.
take hints. When an examiner gives you a hint, you have to take it. Now,
Yeah.
in this particular case, your thought process was very good. I liked this. 20 years old, I gave you a history. I gave you a history that has got backache, etc., for five days at home. So
Yeah.
your was observation was good about atrophy. And one thing is that there is diffuse white matter abnormality. Now here, you cannot expect to gain anything out of a T2 versus a flare. You will never gain anything, T2 versus flare with this kind of pathology. You have to go keep thinking, I want to do DWI, I want to do this, I want to do this. Now, this is a case of fat embolism, and it's a classical case of fat embolism. Fat embolism can occur even in cases of trauma. Please remember, femur fracture or bilateral femur fracture, etc. They go at a particular location and there will be shower of emboli. You will only see it on a SWI sequence. And the classical location include the corpus callosum. If you see, the corpus callosum is involved, the geno and the splenium, the internal capsule, etc. Subcortical white matter, U fibers will be involved. It's bilateral, symmetrical. So this case was actually sickle cell disease. And if the Viva would have gone into that, because I had told you that backache, etc. And this is actually the sacrum and the what we call the pelvis of the patient, and you can see all of these infarctions. You can see these infarctions. So sickle cell disease, please remember in the main your Viva, both sickle cell should be in your mind and trauma should be in your mind. And from today, this appearance should be in your mind. We call it walnut kernel pattern of on SWI. You should have asked for DWI because in the first 4 days or so, there can be restricted diffusion. And this is why I told you in the history that the patient stayed home for 5 days or so. Usually after 4 days, there is no restricted diffusion. I did not show you DWI. I think you never asked for it, but there was no restricted diffusion. So this was a case of fat embolism of sickle cell and because of necrosis. Thank you.
Thank you, doctor. Thank you very much.
Okay, now last case, last candidate. Candidate four, yeah, I think you can hear me. You are unmuted, isn't it? Candidate four.
Yes, sir. Assalamu alaikum. Can you hear me?
Okay, so now this is a 32-year-old male with foot pain.
Okay. Okay, sir. I'm provided with the frontal and lateral projection of a 30-year-old male patient who has presented with the foot pain. Uh, sir, can I window this?
Yeah, better?
Yes, sir. Better. Sir, I can see that there is there is no fracture or dislocation in the first instance, but I can see that there is widening of the subtalar joint
and I can see that there is a bony protrusion that is forming joining with the adjacent bone in the arising from the calcaneum and adjoining the talus bone. So this could be
Where is the protrusion? Can you can
here.
you
I
ask
can see
for the
there's a
mouse control?
bony. Yes.
Mouse.
Oh, okay.
Yeah.
Yes. Now can you see that?
Yes. Can
Sir,
you
yes, this is a bony projection that is arising from the talus. And
are you showing us? Are you
hello.
moving your mouse? I wanted you to point out the finding you are
Yeah,
referring.
yes, I'm moving my mouse. Can you see my mouse?
Okay, I think there is a technical issue. So please describe it. Whatever you are saying, just describe it. I cannot see your mouse.
Okay, sir. There is a bony projection that is arising from the calcaneum and it is joining with the adjacent talar bone. So,
Where is the talar bone and where is the bony projection? So can you see my mouse or not?
yes, sir, I can see your mouse. Yes.
Okay. So are you
No,
talking
sir.
about
So
this
this is
projection?
no, sir. Sir, just
What is
below
happening
this.
here?
So there is a projection from the talar
Okay.
bone, beaking of the
And then
talar bone, and there is coalition of the yes, sir. So there is coalition of
talking
the
about this. Mhm.
yes, sir. Yes, I'm talking about this beak, which you just
Right,
mentioned that.
right.
Yes, so there is a fusion of the tallow coalition of the tallow calcaneum, and also I'm suspecting with the navicular bone as well, but I can see that navicular bone cortex appears to be intact, and there is a space between that. So, so this is likely a case of a coalition, tallow-calcaneal coalition. So, sir, I will inform a finding to the referring physician and would advise CT for further, sir, characterization.
So I've got an MR.
Okay.
Which view do you want to see?
Okay, sir. I would like to see sagittal first and then axial as well.
So okay, this is a sagittal.
So this is axial T2 fat set sequence, uh, in which I cannot see any bone edema or any fracture or dislocation. Uh, uh, yes, sir. Here I can, yes, sir. So here is the pathology. Here there is a, yes, sir. So this is tello, this is calcaneo-navicular coalition.
Calcaneonavicular coalition. So what are you going to advise?
Sir, this is a bony bar that is adjoining the bone. So, sir, I will inform my finding to the referring physician and would refer this patient to the orthopedics for further management of this case.
Anything else you are going to advise?
Sir, so, uh, so bone scan can be done to see if there is any uptake since the patient has history of pain. So, sir, this could be due to any underlying uh, so since MR is very sensitive for edema, I cannot see any edema. So, and I cannot see any abnormal collection of fluid in this region. So this is less likely to be due to any infective etiology or any other. Okay, so this could be
What
any.
are the most common types of collation in the foot?
So these are so calcaneotalar and calcaneonavicular. So these coalitions are common in foot.
Mhm. On plain X-ray,
Yes, sir.
the talocalcaneal collation
Yes, sir.
versus calcaneonavicular collation, which view is the best view to see them? To
Sir, so C sign we see in the on the lateral view.
see
Where there
sign.
is
My
yes,
question is, which view is the best view?
sir, lateral view.
You will see calcaneonavicular collation on
Sir,
lateral
on
view.
axial view, sir. Oh, sorry, AP view, sir. AP.
Okay, thank you. Next, this patient is 24-year-old, has got polyuria and polydipsia. So they have asked for an MR of the pituitary.
Okay, sir. I'm provided with the MRI brain sagittal view of a young patient who has presented with polyuria. This is the T2 weighted sequence, and I can see that the pituitary, I can see the pituitary gland, and there is no mass lesion. There is no ballooning of the pituitary, and uh, so the visualized brain parenchyma appears normal. There is no herniation, or there is no tonsillar herniation in these provided images. Sir, I would like to see the T1 weighted sequence of this same. Yes, sir, I'm looking for the posterior pituitary bright spot to see the posterior pituitary gland, and it is not visualized in these images. Um, so keeping in view the history of that, I'm thinking why there is loss of that bright sign, since I cannot see any abnormal mass or any compression of the pituitary gland. So, sir, can I have other sequences as well?
Which one are you asking for?
So coronal contrast or coronal.
Coronal contrast.
Okay, so these are coronal MRI images of the same patient. So the pituitary glands appear normal. Anterior pituitary gland appears normal on this. There is no deviation of the infundibulum. The optic chiasm appears normal. The cavernous sinus. There is no abnormal signals, and the visualized brain parenchyma also appears unremarkable.
So what is your conclusion?
So the only finding I found is that there is a loss of the posterior pituitary bright spot that is raising concerns for the patient's symptoms.
So what will you tell the clinician then?
Sir, likely this is, sir, I cannot see any abnormal enhancement to say like hypophysitis or anything else. Mm.
So what do you call this condition?
Sir, it really skips out of my mind. That's why I'm just trying to catch those points.
How many types of diabetes
Diabetes. Yes, sir.
insipidus? How
Yes.
many types are there?
So diabetes, types of diabetes insipidus.
Yes.
Sorry, sir, I don't know.
What is the role of imaging here?
So to confirm the cause of lack of the hormone released by the posterior pituitary, central cause, so to rule out the central cause.
Where are these hormones produced?
So they are produced in the they are produced in the hypothalamus, and they are transported into the posterior pituitary gland.
Mhm. Okay. Last case of the day. This is a 73-year-old male patient. He came to the A&E with headache, mood swings, agitated patient. Uh, Actually, the wife brought him. He is 43-year-old. Main symptoms is headache.
Okay, sir, I provided with CT brain plane axial slices
And this headache is
of a
going on.
43-year-old.
Excuse me. One thing which I wanted to highlight, this headache is going on for a while, for a few days.
Okay. Okay, sir. So okay, I'm provided with CT brain plane, and sir, you are scrolling for me.
Have you got the code? Try it. Try it.
Okay, sir. Sir, I will once again go through the entire stack. Sir, I'm looking at the ventricular system, which is not dilated. But the thing I can see that there is effacement of the sulci and gyri, that is, there is diffused loss of the extraaxial cessive spaces in these visualized images, and I can see that there is an abnormal hyperdense area along the posterior parieto-occipital region that is slightly lobulated, and the ventricular system, sir, is also compressed and it appears to be slit-like. So there is no, I cannot see, sir, any extra axial. This is some suspicion of subtle hypodensity along the sir, left frontoparietal region. That could be a subdural collection. Yes, sir, this is a subdural collection, and I cannot see any high density within it. It appears to be hypodense. And yes, sir. So, sir, this is a subdural collection involving the right frontoparietal region with generalized cerebral edema. And sir, I would like to go for this is an emergency, and I would immediately
Right, left, where?
Sir, it is on the left side involving the fronto and parietal region, extending
Anything on the
posteriorly.
right side?
And yes, sir, there is suspicion of subdural collection along the right side as well. It is slightly, it's very subtle, but it appears to be that there is something that is causing
So what will you do?
Sir, this is an emergency and this patient requires immediate neurosurgical consultation, and if possible, then we should go for MRI with contrast to see the extension and to see the cause and to
What
see.
are the neurosurgeons have to do right now?
Sir, this patient has impending risk of impending herniation, so they will clinically assess this patient since there is generalized cerebral edema.
How will the neurosurgeons make a decision on this scan?
Sir, since there is generalized cerebral edema and effacement of the sir, all the basal cisterns, so sir, the raised intracranial pressure and papillary edema, and
Okay,
sir, this
you want to do an
impending.
MR.
Yes, sir.
Okay, so this is an MR.
Okay, sir, I'm provided with the MRI axial slices. This is a T1 weighted sequence. T1 weighted sequence, which I can see that there is bilateral subdural collections and they appear homogeneously hyper intense. Sir, I would like to see subsequent T2 weighted sequence as well to characterize the age of the subdural hematoma. Yes, sir, it appears hyper intense. So this is likely a subacute state, likely late subacute stage of the hematoma. And furthermore, sir, I would like to see any other cause or any other pathology. Sir, I would like to see the sagittal images to rule out tonsillar herniation.
I've got only this
Okay.
one.
Okay, sir, T1 weighted sequence. No, sir, there is no definite tonsillar herniation in these provided images. However, sir, I will inform my finding to the rep.
So what is
Sir,
your
there
control?
is a suspicion of. So there is a decreased distance between the mammillary bodies and the midbrain as well. So do we have contrast images? Axial contrast images. Okay, sir, I can see that there is a diffuse pachymeningeal enhancement. Okay, sir.
Okay, just
yes,
conclude the case now.
so this is a case of intracerebral hypotension. and that is causing the patient's symptoms and engorgement of the venous sinuses and sagging of the brainstem and diffuse pachymeningeal enhancement.
Okay,
So I will
thank you.
inform my finding to the referring physician, yes, sir. And would advise neural access, entire neural access MRI for further evaluation and to rule out the cause of that leak, CSF leak that is leading to this condition.
Okay, thank you. So this was your first case. Now, your observation was fine, but the point is that a calcaneo-navicular correlation cannot be visualized on a lateral view. It cannot be visualized on an AP view. The best view for calcaneo-navicular correlation is an oblique view of the foot, and this is a viva question, and you have to ask for an oblique view. So this thing is the anterior process. You can say that it is very prominent. I want to. So where is the correlation? You will never ever pick it up. The key finding here is this: you have to describe the talar beaking, and then this tells you that something is wrong. And another viva question which I did was, what will you do next? It is a classical viva question. Other foot, that is the answer. I will. These cases are up to 30%, 35%. Some studies tell us bilateral, some studies tell us about 15% bilateral. So the key thing is that this patient was 32 years old. Till 32 was not diagnosed with correlation. And you have to ask for the other foot, and that is what the answer is. So on plain film, once again, I repeat, the two most common correlations you were correct there are talocalcaneal and calcaneo-navicular. Calcaneo-navicular, which is this one, the best plain film view is oblique view of the foot. For talocalcaneal, you were confusing, in some of blatant cases, definitely C sign can be seen on a lateral, but the best view is axial. So that was the answer. Now, as far as management is concerned, now you got confused. You picked up the finding very well and you got it. You just, this is where you had to go for the next case. Just finish it and go. So nothing else to be done. Uh, what needs to be done was the other foot. There was absolutely no role. You got confused. Talked about nuclear scan. You then corrected yourself that there is no edema. On a PD, non-fat saturated, you can see this bony bridge there. So I had a few viva questions there, which I did not ask. This you did very well, actually. You did very well. Just a bit of fine touch. You after this you asked for a T1 weighted sequence. Please remember that diabetes insipidus has got two types, central and nephrogenic. So kidney or central. When they do MR of the pituitary, the role is to rule out any lesion there, and indirectly, actually, you did rule them out. So I like that. Any hypophysitis, any other tumors, etc., etc., you rule that out, even trauma or post-surgical, etc. When you rule them out, then you call it idiopathic. Idiopathic means that there is no cause, and the diagnosis is based on the same thing which you very correctly pointed out. That the oxytocin and ADH, it is produced in the hypothalamus. It goes into and stored there in the posterior pituitary, and because of proteinaceous content, etc., they are high signal on T1. Please remember, it's not fat. It's different physics there. So they are high signal, and I think you did very well, except for one odd viva question, which was regarding a bit of theoretical knowledge. So this was well done. But you could have been more elaborative there on post contrast on post contrast, you could have the idea of talking through the scan, your thought process. Thought process is that you are ruling out a microadenoma, and then in conclusion, you say that the only thing which I have picked up is that non-visualized, and this is in keeping with idiopathic diabetes insipidus. This case uh, is in the territory of the eye nose correction. The interpretation also is on your theoretical knowledge, your radiology knowledge. Please remember, in the end, you got the diagnosis, but the way you got the diagnosis was, because you took so much time there, and maybe the Viva time had finished by that time. Please remember, in idiopathic intracranial hypotension, what happens is correction. It's not idiopathic correction, it's spontaneous. Spontaneous intracranial hypotension. Don't confuse it with idiopathic uh, intracranial hypertension, which is also known as pseudotumor cerebri, the old terminology. Here, what is happening is that the CSF, for some reason, it gets decreased, and there is a concept of primary, which is with a reason. Let's say you do a LP or a lumbar puncture, sorry, spinal surgery or trauma, etc. There is leak of CSF, and then there is spontaneous. The etiology of spontaneous is a big subject, which is beyond your 2B level, because it can be in the spine. There are various types. For example, there can be, because of osteophytes in the thoracic spine, there can be dural tears, etc. And when you do MR highly T2-weighted sequences, you might see a pool of CSF, which tells you that there is a tear. But there are other types in which there is a CSF, venous fistulas, etc. It's too complex for 2B world, so don't worry about it. The main thing is to make the diagnosis in the brain. So what happens in the brain, that as ultimately the candidate pointed out correctly, that the equation where intracranial volume has to remain the same. There are three things in the brain. One is blood. Blood is within the vessels. Then is water. Water is in the parenchyma of the brain, and then is CSF. So if one thing decreases, other has to increase. The Monro-Kelly hypothesis. And this hypothesis, by the way, is asked in the exam vis-a-vis trauma. It will, here, the same application is there. The CSF is decreasing. So what is happening? The blood vessels are increasing. And what will increase? Because the veins are more compliant, they will dilate, and particularly in the dura. So it's a misnomer that there is dural thickening. Actually, the veins inside have become engorged. And then these leaky veins can cause subdural hygroma. Hygroma is water. It's not bleed. So the way you handled it in the beginning, no neurosurgeon will ever deal with this case. They will ask first of all for, further imaging, what is happening. So the answer was MR. You, in the same breath, you said that I will neurosurgeon urgent referral, and also if possible MR. So no neurosurgeon will ever deal with this case. Now, so in this particular case, what is happening is that there is a CSF, a hygroma also. Now, in the MR, what happened was that I intentionally gave you a flare sequence. And because this was a giveaway actually, but you got confused that on the flare you made it actually a T1. Please remember my basic teaching. I always say that you can confuse a flare with a T1. This is a T1. On a T1 weighted sequence, white matter is white, though the CSF is black. So this is a T1. where the white matter is white, and then where is the flare? So this is the flare. Now, if you get confused here, just look at the white matter and it will be black. So this is a flare sequence. And because of this, you then, you convinced yourself that these are subdural, what we call hematomas. Please remember, even in high chromas on a T1 weighted sequence, they can be high signal because of proteinaceous content. But in this particular case, this was it. The key thing was that on the flare, then you should have asked for contrast. End of story. And on contrast, you can see that there is enhancement. Actually, if you see here, there is a thin rim of fluid also, which is not enhancing in addition to this. And so this is enhancement. And you did pick it up once I showed you the sagittal. This is post-contrast sagittal, where you can see, the midbrain is sort of drooping down, and a pituitary gland is also quite congested, prominent there. So this was intracranial hypotension. And if you see carefully, even here, there is enhancement in the cervical spine. Okay, then, thank you very much. So the key thing what we have learned from the Vivas today is try to learn to, for all of you, not for specific, try to learn to sort of finish the case, complete the case, get it over, and then stop. Then stop. Don't keep talking. If you are talking, the examiner are going to allow you to talking. By the way, now it's not going to be like that, because they will push you and they might interrupt you. Even then, what happens is that sometimes some candidates have not completed their viva. And the reason is that even by the pushing of examiners, they could not. So you have to, all the time, when you do your practice, you the headings which are in your long cases, they should be in your mind. You start describing the case, and then your interpretation means describe the finding and the interpretation, and reach a differential diagnosis according to the clinical history or age or whatever is there. And then there should be a principal diagnosis, and in some cases there will be a principal diagnosis, and then will be management. And all of that has to be in one go. Number two is that in the exam, if you go to the RCR websites, there are even mock vivas there. It tells you that in the exam, it will not be like what I have here. They now have got specific sequences, specific, two sequences only, and they will just show you those two sequences. So, and only at times what happens is that they will like you to make the diagnosis